I'm Lynette Beery. I'm the director of the Bureau of Family Health Services at MDHHS. We are so excited to have you all here. Cannot tell you how excited we are. We are an amazing group this morning. With me on the stage, and they'll tell you a little bit about their titles, but we purposefully wanted this to be sort of a group activity, if you will, to launch the summit today. We feel pretty strongly that it takes a village to do this work. You all know that on the front lines, even more so than I do. But up here with me this morning is Dr. Bob Sokol, who co-chairs our Maternal Mortality Medical Surveillance Committee, and he and I co-chair MIAM together. Dr. Sonia Hassan, a researcher from Wayne State, who co-chairs our infant mortality work, which we now call the Mother-Infant Health and Equity Collaborative. It used to be called the Infant Mortality Advisory Council. And the most amazing Nina Sassy, she'll tell you a little bit about her title in a minute. As all of you know, it takes truly a village to put an event like this on. Members of the Planning Committee, of course, have a ribbon, but would you folks that were on the Planning Committee stand up for just a quick moment so that folks see who you are? I know. Thank you. Yes, absolutely. But I do want to give a special shout out to Nina Sassy and Laura Drayton, stand back up, and Shatoria, stand back up. And where's Laura Howdeshell? In a red dress somewhere. These four women have done, there she is in the back, amazing, amazing work to pull this off. You wouldn't be here without them. And you are an amazing group. We are so excited. We have a really diverse group of folks here. So I'm going to ask you by groups to stand up just so you can see who everyone is that's here today. If you're from the public health world, you're a home visitor, you are work in a WIC clinic, whatever, stand up. Great. If you are from the clinical side of healthcare, if you deliver babies, you are a nurse, you're a discharge planner at the hospital, stand up, please. And I want to give a special shout out, thank you, to the physicians that are here. We have quadrupled the number of physicians that are here this year, so we are very excited about that. We know it's really challenging to leave your clinical practice and come to an event like this, so we greatly appreciate that. I do want to also point out Karen McMasters, Senior Deputy for Population Health Administration at MDHHS, also known as my boss, so there you go. Thank you, Karen. And our sponsors. We, of course, wouldn't be here without the sponsors. Special thanks go out to Blue Cross Blue Shield, the MIAM Project, WIC, and March of Dimes. Okay, your folders. Everybody has a little bingo card in their folder. When you go to visit the vendors, please get your card stamped, turn it into the registration desk, and you might just win a little prize for going to see the vendors. There'll be, I think, 3 different drawings today. One last thing, I want to thank all of you very, very much. As you're here in part to help us unveil the Mother-Infant Health and Equity Improvement Plan. I think probably most everybody in this room almost had a little piece in the development of that plan. So many of you came to town halls last summer and during the fall, came to a MyHEC meeting, got on a webinar, went to a learning collaborative, and we greatly, greatly appreciate all of the input, as well as most recently, the written version of the plan has been out for public comment, and many of you have submitted comments to that through that venue as well, and we greatly appreciate that. As you know, it will take all of us to implement this plan. It will be a heavy lift, but we are up to the task. I absolutely believe that we can do it. It is an iterative plan, so at any point, we have said all along, this is not carved in stone. At a minimum, we're going to be looking at the plan annually and reevaluating, do we need to do things a little differently? So at any point, please let us know if you have additional input. And with that, I'm going to let Dr. Sokol say a few words.
Good morning. I think I'm going to sit down. Anyway, I'm Bob Sokol. I'm an OBGYN, and I chair the Medical Maternal Mortality Committee of the state. I'm an emeritus professor at Wayne State and co-chair with Lynette, my aim. We have a giant full agenda today and tomorrow, so we're going to need to really move things along. In fact, for those of you who were here last year for the summit, you're going to see this is quite different. It says a little different here, but nah, it's I think much better. And we have 3 themes this year, and the intent is to bring together the different disciplines, and you already saw a little bit of this, that are necessary to do the work we're trying to do. Each of the themes is going to provide an opportunity to hear from clinicians, public health people, and community leaders. The idea of this format is to promote collaboration between maternal and infant health leaders across the state. I actually think this takes more than a village. It takes the whole state to do this successfully. Now, I would like to recognize the group that Lynette and I co-chair. Would everybody from the My Aim Steering Committee and Operations Committee stand up to be recognized? These folks meet all the time and work very, very hard. We have a major public-private consortium and partners. Key partner is Michigan Health and Hospital Association as we work on implementing the OB hemorrhage and severe hypertension pregnancy safety bundles in hopefully all of our birthing hospitals throughout the state, as well as other partners including ACOG, AWAN, the nurse midwives, and so on. We have a slide on that later. We are starting to see some improvement in our hospitals, implementing the bundles and getting reductions in severe maternal morbidity. Later this afternoon, we'll close the program, in fact, with the My Aim update, and we'll recognize the My Aim designated hospitals. Last year we had, what, 5 hospitals? 5 or 6 hospitals. This year we have 16 gold hospitals, 7 silvers, and 28 bronze designated hospitals in Michigan. And let me turn the microphone over to Dr. Sonia Hassan. Sonia? I don't think you're on.
Hello. Yes, it's working. Thank you. So good morning, everyone. It's really a pleasure to be here. I'm Sonia Hassan. I'm Associate Dean for Maternal, Perinatal, and Child Health at Wayne State University. And I first wanted to start my little few minutes here to introduce some very special people here that, and then give us sort of a call to action as well. So first, I wanted to acknowledge a very special group, my fellow Maternal Infant Strategy Group members, of which many of you are here. And these are really experts and decision makers in the public, private, and academic health centers around the state. We've come together, and I want to just name off everyone. I know it seems lengthy, but I think it's important what these individuals do, and perhaps if you could stand, please, to be acknowledged. Matthew Alsweed, Bernice Anthony, John Barks, Colleen Berry, Charles Barone, Lynette Bieri, Brittany Bogan, Nikki Britton, Renee Canady, Deborah Darling, Stephanie Flom, you're not standing, no. James Forshee, Canada Green, Herman Gray, Teresa Holtrope, Jonay Caldoun, Elizabeth Cushman, Karen McMaster, David Neff, Cheryl Larry-Osman, Lisa Peacock, Nina Sassy, Dawn Schenefelt, Robert Sokol, and Amy Zagman. So if you could join me again in thanking these individuals for their help. Again, this group provides guidance on the development of the improvement plan, as well as some guidance on implementation and measurement. Most importantly, the work that is done is also, from that group, is to ensure that this adequately addresses equity as we go forward with all of the plan. And so that has been on the keen agenda. Next, a small call to action to you after you've completed the summit. There's a wonderful group of people here. Everyone is around the state with their different causes of whether it's infant mortality or maternal mortality. And the way to sort of either showcase the work or to stay together after this is to keep going throughout the year. So I'll ask that if you please become a part of the Maternal Infant Health and Equity Collaborative meetings that Lynette mentioned. Everyone is doing important work in the state. This collaborative provides a way that we can all share our work, connect, and then sort of join forces together. Again, everyone has a different focus or a different perhaps cause for whatever is going on in their area, but I think together it's stronger than separately. I've had the pleasure of co-chairing those meetings with Amy Zagman, who is over there. Thank you, Amy, the Executive Director of the Michigan Council for Maternal and Child Health. And Amy, please stand again. The purpose of our MyHack is to support and champion the Maternal Infant Equity Improvement Plan. We, again, use the varied organizations' visions in a way trying to sort of bring them together and synergize them in the best way possible. So everyone is available to attend those meetings, and there is information on how to join them in your packet as well, and please, I encourage you to do so at the end of the meeting. Lastly, I wanted to thank Lynette and Nina for their leadership through all this, for which none of this would be possible. So thank you.
Good morning. I'm Nina Sassy, Senior Maternal Child Health Strategist. Before I introduce our opening panel, I did want to remind everyone to download the Summit app if you haven't already. So within this app, you'll find the speaker bios, you'll find information about our vendors, we'll have surveys and polls that you all can answer, and it's a great way to stay connected with the Summit. So just make sure that you download it. There's instructions on your table. You can stop by the registration desk if you have any problems, but please make sure that you download it. Now, I'd like to introduce the speakers of our opening panel. Dr. Herman Gray, who is the Chair of Pediatrics at Wayne State University. Cheryl Larry-Osman, who is the perinatal nurse, clinical specialist. It's a good thing I memorized this right. At Henry Ford. And Dr. Melinda Johnson, who is the Vice President and Department Chair of Women's Health at Spectrum. And Dr. Renee Canady, who is the CEO of the Michigan Public Health Institute. And the name of their segment is Telling Stories, Truth, Lies, and the Narratives That We Build.
Good morning. That distinguished gentleman on the right is my dad, Dr. Herman Gray Sr. My dad was a pharmacist who immigrated in the mid-40s. He was about 15 years older than my mother, to the United States from the island nation of Jamaica to attend medical school in Boston. Unable to find affordable housing in Boston that would also accept a black tenant and needing to support himself, my father worked as a dishwasher at night in New York City, then boarded a train to Boston. While on the train, he slept and studied, and that's how he worked his way through medical school. My mother, that little short person there at the bottom on the left, was a high school graduate in Detroit who was a receptionist in a doctor's office. One day, my dad visited one of his buddies in that office and became very interested in the receptionist. They ultimately married, and I was born in Detroit. My mother was a living example of service to others. She loved God, and she loved helping people. My dad, a gifted general surgeon, was unable to practice medicine in any of the white majority hospitals in Detroit. He would work during the week in small town hospitals out of state that were so desperate for doctors that they would accept a black physician. He drove home on weekends when he could. He moved back to Jamaica in 1963 when the country got its independence from Great Britain. because he said, "A man can be a man back home." As a small boy, I didn't understand the underlying injustice that he experienced. One generation later, his son, Dr. Herman Gray Jr., would become president of one of the DMC hospitals that my dad could not practice in. This picture on the lower left is at my medical school graduation in 1976, and yes, you can do the calculations. I believe it's the last picture that I have of my mother and father together, witnessing a dream fulfilled. Lastly, and most importantly, the upper left corner is my nuclear family. That includes on the far right, on the right side of the sofa there, my life partner, my best friend, the love of my life, Shirley Mann Gray. Monifa next to her, our oldest daughter, a lawyer, and Dara, a social worker at a FQHC, is our youngest. Family is everything to us. Additionally, legacy and the future are really important to us. Certainly my dream for Dara and Monifa has been that these young women grow up in a better world where their voices are heard. My parents taught my sister and I about service and justice, not by what they said, but by what they did and how they persevered. Service to others, we are our brother's keeper. Justice that must be fought for and struggled for. All men are created equal. Legacy and looking forward. I owe them both so much.
Good morning. My name is Cheryl Larry-Osman, and I'm a clinical nurse specialist at Henry Ford Hospital and an AWAN member. Hope is a thing with feathers. Hope is a thing with feathers that perches in the soul and sings the tune without the words and never stops at all. And sweetest in the gale I've heard is heard, and sore must be the storm that would abash the little bird that kept so many warm. I've heard it in the chillest land and on the strangest sea, yet never in extremity it asked a crumb of me. In 2005, I had been a clinical nurse specialist for about 5 years at Henry Ford Hospital, and our patient population bordered between high risk, low risk, and moderate risk. So it wasn't uncommon for us to see complex patients come into our service. At this time, there was a young patient that came into the OB service. She was 23 years old. She was pregnant with her second child. She had been in and out of the emergency rooms with a cough. And she was treated and sent home, treated and sent home. But at this last time she came to the hospital, she had her cough was more progressive, and there was an X-ray taken. And during that time, when they were waiting for the results to come back, certainly she and her family were frightened about what was going on. They also she discovered shortly before that she was pregnant as well. She was about 20 weeks pregnant at this time. When the scans came back, they noticed that both of her lungs were very cloudy, and when they did a further investigation, they found out that she had bilateral bronchioalveolar lung cancer, and stage 4. So she was 23, she had a 2-year-old, and she had stage 4 lung cancer. So of course, there was a lot of fear with the patient and with the family as well. And to give you a little background about her, she was a Hispanic patient. She spoke limited English. She had an identical twin sister. And if you saw her, she didn't look sick. She was absolutely gorgeous. She was someone who just was always gorgeous, made up with her makeup and everything. She had a very strong family support as well. She had a husband But we weren't sure at the time if they were married or not, but she had a very strong support person. Her parents were in Mexico. So as it progressed, we were concerned certainly about what to do because she's pregnant. At that time in 2005, the use of chemotherapy as it is today was even more controversial. But with her case, that would be the only thing that could help her in this situation. What we did find out is that there was nothing that we could do to save her life. And that was difficult for anyone. And it made it even more complex because she was pregnant and we couldn't save her, but we could save the baby, or we could try to. So we had a lot of decisions to make with our team related to what to do and how we can get her through this very difficult time in her life. So we made a decision, and we had a conference call with, or a very large multidisciplinary meeting with several services: OB, NICU, oncology, radiation oncology, social work. Social work was heavily involved because we had to determine paternity, because we had to determine who was going to go home, who was going to take care of this baby for this mom. It was a crisis for the family. There was evidence of fear and hope and anger and trust. And as we cascaded through this whole event, we did many things very well as we took care of this mom. But we did learn a lot of things about certain aspects that we could have done better related to communication. She didn't speak English very well, so partnering her or having someone within our team that she could bond with, she and her family. They were also Catholic, and from a spiritual standpoint, we were trying to also provide that and fill that space for her as well. Initially, there was very much resistance against the spirituals. From a spiritual sense, we offered pastoral care. They said no. They were going to seek their own services, which is fine with us, because we thought that was part of the picture that she needed at that time, because she was in a crisis. There was a lot of anger as well, because we as clinicians, we were trying to solve the problem and give our recommendations on this is what you need to do. But the family was like, no, wait a minute, this is what we need to do as a family. And one of the complex things involved the family's desire for us not to tell the mom that she was dying, because their fear was that if she knew she was dying, that would take away her hope to live. So as clinicians, that put us in a challenging situation, because we could not tell her, we could not hold back that information related to her condition. However, we didn't want to destroy her hope for living. So hope was a big part of the story of this mom. And eventually what happened, we involved the ethics team, and it was a very difficult situation for all of us as clinicians. She was in the ICU. She eventually was on a ventilator because of her respiratory status. We did start chemotherapy on her at about 20 weeks of pregnancy, and our goal was to get her to viability. One of the complex aspects about the situation is when we were trying to get her to viability, the patient and the family heard that we were going to deliver the baby. But once she got to 24 weeks, we wanted to continue, and there was like a breakdown of trust now, because they didn't know the baby. They knew the mom, so they wanted us to be more aggressive in our treatment. One of the radiation oncologists told us in one of the meetings that based on her condition, she would survive maybe about 4 weeks. And at about 24 weeks gestation, her water broke. We had made a plan to deliver her, but we weren't sure if she was going to survive. She was still on chemotherapy. She was vented. And she had eventually accepted spiritual counseling from our team as well, and we built that connection back with the family that had broken down. At 24 weeks, she ruptured her membranes. We delivered her via C-section. She was then placed with the hospice service and went home for a couple of weeks. After that time, she decompensated at home, came back to the hospital, and she didn't survive that last admission. The baby went home with dad, and this was in 2005, and from what we know at that time, the baby did well. We established paternity, which was we established paternity. We got the family here with the involvement of immigration, and we really worked hard on communicating well, instilling hope, and instilling spirituality. So in many cases in OB over the years, we've had very complex patients, and certainly there are some moms that no matter what we do, their situation brings brings us to a point where we cannot save them, but it doesn't mean that we are losing hope for what they have left in their life and hope for their child as well. So as we move forward, and when I think about my why of why I do this every day, is built upon the zero preventable deaths that we have as our mission, and knowing that my hope is that every mom goes home with her baby, and every baby goes home with her mom, and that we prevent any death that we can. Thank you.
There are so many great stories in this room about why we do what we do to support the health and lives of mothers and babies. My professional journey is rooted in people. I have been influenced and inspired by so many. My family, teachers, patients, colleagues, and communities. Like many physicians, I was drawn to the profession by the desire to help others. I loved science. I was curious about how science could help society. I like working with people and finding practical solutions to problems. In medical school, I loved my OB rotation, and after watching my first delivery, I was hooked. I think many are drawn to the field of obstetrics and gynecology because of the births. Birth is one of the few happy reasons that people go to the hospital. Of course, I was also fascinated by other aspects of caring for women, and after residency, I was delighted to join a full-scope private practice. Over time and with age, my perspective and desire to help people matured. When I reflect back now, in preparation for today, I would say that there are two important career events that helped direct me to my current place. The first was a transition from 9 years in private practice to join the Spectrum Health residency practice and core faculty team, where my focus turned to caring exclusively for women with medical and social complexities. My charge was to teach and supervise residents and to care for a disadvantaged and vulnerable patient population. The second career experience was the time I served as a medical director for Medicaid at Priority Health. These years were completely mind-blowing to me, almost as if a switch was flipped inside me and I started looking at the world in a different light. It opened my eyes to seeing patients or members holistically. 10 minutes in an exam room with a patient is only a tiny slice. I thought I knew my patients, and then I learned about claims data. I worked with amazing care managers in the health plan that could see and help patients in a different way. They could see whether prescriptions were picked up, whether appointments were kept, whether specialists were seen. They knew whether transportation was needed. And we could see outcomes when care was coordinated and when it wasn't. I learned about population health, social determinants of health, resource stewardship, actuarial science, clinical variation across the network, and it all gave me a much deeper appreciation for the complexities of health plans, health policy, and the challenges involved in changing human behavior and ultimately caring for people. So my career journey has been challenging and delightful, and helping people is still my compass. But now, in addition to helping one mother at a time, I think about how to change systems and models of care and to be able to make a difference on a larger scale. To make a difference for moms, babies, fathers, families, and communities, an impact that will hopefully last for generations.
At 28 weeks, my pregnancy was abruptly ended. due to my escalating symptoms of preeclampsia. Following a routine OB visit, my doctor sent me immediately to the hospital. Yeah, do not pass go, do not collect $200, do not go home and pack a bag, straight to the hospital. After a day on my left side and being pumped with steroids, I was awakened by staff coming into my room to prep me for an emergency C-section. Wait a minute, are we gonna discuss this, I said? Are you gonna explain to me your thinking? And the response was, oh, we already talked to your husband. So off we went to deliver Mark Howard Canady II. It's interesting that after 30 days in the NICU, you become eligible for what then was referred to as Crippled Children's Services. Thank God they have now changed that name to Children Special Health Care Needs. But we had to meet with a social worker to complete the process and get him registered. And as we were beginning, she stopped the conversation to say, this is actually a really difficult conversation for me to have because I'm just not convinced that your son is going to survive. So with a pause and a breath, I said, perhaps we should find a colleague of yours who does. Oh, no, that's not what I meant. That's not what I meant. I'm also struck by Howard spent 6 months, most of that in NICU, and the last several weeks in PEDS ICU. And it was always interesting to me, the conflict and the tension, all clinically justified and well-intended. The neonatologist's goal was getting the baby breathing room air. We've got to get him off the vent. Get him off the vent was the goal. Put him on room air for a while, fail. You have to remember, this was in 1989 when the high-pressure ventilators were brand spanking new. We weren't sure if insurance was going to cover it. There was only one in Ann Arbor. We were here in Lansing. But this tension back and forth about room air, room air, room air. When we got in intimate relationship with the PEDS intensivists, their goal was weight gain. Let's help him breathe. Matter of fact, let's trach him so that he doesn't have to burn calories trying to breathe through crumbly lungs. The narrative had shifted on us, and the perspective and goals had changed. So it was this continuing journey of whose voice matters. Was it mine? Was it my husband's? Was it the social workers? Was it the clinicians? And what indeed was the story that would be told. My 3 surviving sons are a reminder for me every day of the beauty and the privilege of life and loss, including my oldest son on the far left, with the beard and missing hair up top. They all know their brother, Howard, to a very deep and intimate way. I wasn't sure how we would include him in our family. But at one time I was scolding my older son when he was about 8 and explaining to him that he was the big brother and he had to be a role model. And he suddenly burst into tears and he said, "It's not even fair. I'm not even the big brother, really. Why isn't Howard here to help me?" Well, you can imagine that that lecture ended really quickly with a big, big hug. But there is purpose in life, we know, and there is purpose in loss. And our family, which again and again, every delivery, I kept thinking, maybe a girl this time. And a voice in my spirit just reminded me that I serve a God who restores. And by the third time, I was like, I get it, but can we have a girl this time? Thank you for listening. We're going to come up to the panel and talk with you a little further. When I was growing up, we were not allowed to use the term liar, to call people a liar, or to say, you're lying. We used instead a term, you telling a story, because we knew we'd get in a lot of trouble for using such a harsh and rude word as lying. But we also know that sometimes folk tell stories about the experiences of moms and their babies, not to intentionally lie, but through their misinterpretation of the lived experiences of these moms. And so there now is an increasing use of the term storytelling as opposed to telling stories, right? A subtle distinction. But we wanted to invite you to think about your stories, to think about the narratives that resonated around you so that you're clear on why bother. This is, as Lynette said, a heavy lift. When she first said it, I was thinking, no, I don't want to think about a heavy lift, but it is a heavy lift. And so it is the motivation, the stories, the legacy that you heard from Dr. Herman, the commitment, the clinical commitment, and the tension between the needs of the family, the needs of the baby, the needs of the mom, and the privilege of being the torch bearer for so many people that have invested in us is vital to helping us be effective collectively. So we're going to just have a little bit of a dialogue, and thank you all for trusting the process. I was getting text messages saying, are you guys gonna go up so we can see you? Oh, ever the problem solvers, ever. So let's talk, guys, a little bit about these issues of stories. And it seems to me that over years of experience, and none of us are new in our field, we probably have heard some of the same stories over and over and over again. So I'm inviting you to think with us, but what are some stories that have resonated, both good and bad, that either, gosh, I wish we could think more like that, or gosh, I wish we would just stop saying that?
I guess I'll start. One of the things, and this is somewhat disheartening, but I feel like there's so many misconceptions. And when we think about the effort to improve health and equity, I think one of the biggest challenges we face are these misconceptions. And one of the things that I have heard many times is that people have said, she doesn't care about her baby. She must not care about her baby. If she cared, she wouldn't smoke. If she cared, she'd show up to her appointments on time. If she cared, she wouldn't try to leave the hospital against medical advice when she was 26 weeks pregnant and dilated. And I think we have to realize that a lot of these women are facing challenges and burdens that we have no idea about, and they're completely misunderstood. And so I think that we need to figure out a way to do less judging and more listening, and finding a way to help these women care for themselves, for their families, for their babies, and to help them juggle the priorities, because it's not easy. And I think that we need to make sure that we start with positive intent in big years.
You know, the word lie wasn't allowed in our house either, for the most part. And as I was preparing for today and thinking about some of the things that I might touch on, I was reminded of something that happened to me probably 15 years ago. I was being honored by a sudden infant death syndrome parent group for work that I'd done for a long time, and went to the airport to pick up my oldest daughter, who was in law school in Tennessee, and younger daughter from Ann Arbor. And I said I was not going to say the words "Go Blue" at all during my time here, but I just can't help myself. So I picked up my younger daughter from Ann Arbor, and then we were driving downtown, and so they were asking, so like, what are you being honored for? And I said, well, my work in sudden infant death. And, oh, well, what is that? Well, that's sudden unexpected death of a previously healthy baby. Well, what causes it? Well, I don't know. Well, how do you prevent it? Well, I don't know. My younger daughter then says, so what the hell kind of expert are you? And we were stunned, or I'm sorry, we weren't stunned. I was stunned that she actually said that to me. And it has remained a family joke about inappropriate language in families forever. But to answer more directly your question, I suppose there's lots of stories of things that you hear, and perhaps going back to my why and the whole justice thing, which in many ways is foundational, is founded upon respect. Respect for our patients is really important, and I've, living in many of my years in a children's hospital, where by definition you have young families, often poor. Even if they weren't poor before the child gets sick, they often become poor because they have to rally their limited resources to do everything they can to take care of this young person. And to hear people describe family members as incapable of understanding what we're trying to tell them when we speak in a foreign language and jargon, when we make no effort to really translate it in a way that is understandable and approachable, I just found and continue to find, because it still continues to this day, really very difficult. I had a patient who I had purchased another pediatrician's practice in my expand to the entire world strategy, which turned out to be a really bad strategy. But I had inherited an office in a family, their little girl had been admitted to the hospital. This is in the pre-meningitis vaccine days, and she had a bacterial meningitis, and it was awful for this youngster. And we got a scan of her head. It showed that much of the brain tissue had been destroyed, and so I had to have this painful conversation with this mother about what the future might look like for her daughter without proscribing it precisely, but what the likely outcome was going to be. And she kept smiling and nodding, and I'm thinking like, one, smiling is not an appropriate response to what you're hearing, and she was clearly limited in her her cognitive capabilities, which I already knew to some extent. And when I finished, and she basically said, "It's going to be okay, doctor." And my response to it was, this may not be the smartest woman that I have ever met, but she could be my mom any day, because what she wanted for that child and her just complete, total refusal to be depressed or put off by what I said to her was really, to me, far more important than 20 IQ points. And I think that judging people by literacy, by dialect, by social circumstance is something that we all have to guard against, whether it's explicitly or implicitly. We all have these biases that we come to the patient interaction with or the client interaction with, and we have to really mind ourselves of that.
I was going to sing, but I'm not going to sing. I've been a clinical nurse specialist or a nurse in general for over almost 25 years now, mostly in OB, 2 years in ICU prior to that. And I've noticed that over the course of these years, the complexity of the patients in my role of OB has tremendously exceeded. And things that I never thought I would see in OB, I'm seeing now. And during this time, I realized that we really have to change the way we are delivering care and asking questions. And it wasn't uncommon for for me and my colleagues as well, and sometimes I still do that, when patients are coming in with complexities, I find myself asking why a lot. And that's not really the right question to get to the answers that we need. Because when you're asking a mother, well, why did you do this or why did this happen, you're in a way blaming them as well. So my question has changed to now, how? How can I help you get the services you need? How can I help guide you to better outcomes in this pregnancy? And with seeing such a high-risk population, and we also have low-risk patients as well, I'm always amazed at the stories that the moms bring to the table, because everyone has a story, as you know. And just to tell you about one patient that just came to mind as I was listening to my colleagues, we had a mother who came in a few years ago, and she was, as we found out, a victim of human trafficking. When she came in, we didn't know that because we didn't have all the pieces of her story. And so we were asking, well, why did you wait so long to come into our service? And why did this happen? And why did these things happen? What we also found out is that she had a cognition problem as well. So she didn't have all of the cognition to notice that she was in danger as well. So our questions quickly changed to, how can we help you get out of this situation? She desperately wanted to take her baby home, but she didn't have a home to go to because she came from a place where she was being held captive. So once we got through the layers of her story, and we first had to build trust with her to get the pieces that we needed to find out to help her. We eventually got to that point where we could help her, but we really had to change our language and listen to what she was trying to say without saying those words as definitively. And in our listening and in our asking how we can help you, we were able to get her set up with the services that she needed so that she could have a safe outcome and her baby as well. So everyone has a story, and some of us are better at listening than others, but I think it's a skill set that we as clinicians need to have to partner with patients and families to find out how we can help them and how we can get the things that they need as they move forward.
I think that's such a vital distinction, Cheryl, that you make, that though we've invited those in attendance to think about their why, and though we even started with our why, when the why is flipped, it's more destructive, right? We need the why to be personally facing and then transition to the how. I think that's an important distinction. I mean, you all have each described dynamics of power in your stories and in your experiences, and certainly mine was just steeped with it was almost like an arm wrestling from who's more powerful, my husband's voice or my voice, who's more powerful, that tension. So, this session is really getting about getting you guys to think deeply so that you're hearing the rest of the summit through very awakened ears, right? We want to be a real woke summit, as I don't even know if the kids say it or not. I'm sure my sons would be cringing right now. But I want to invite you to think about two things, and then we're going to discuss them and really get ready to transition. I want you to think about power, a time when you felt very powerful in your ability to advocate for the well-being of the patients and families that you were honored to serve. And I also want you to think about a moment of powerlessness when you just felt like you were beating your head against the wall. And I know that our panel has thought about both of those, but why don't I invite you to tell the story of whichever is most resonant and most salient for you this now.
I want to thank Renee for this really sort of creative panel that we're participating in, and I want to, curse Renee for making me think really so hard. When you get to be my age, everything is just kind of perfunctory. I mean, I can go on autopilot and talk about myself forever. So thanks a lot, Renee. So I have lots of examples of the powerful feeling because I, borderline delusional tendencies. And so I really have been conflicted over which story to tell and can I do them quickly enough. And so I'm going to try to do a story about Mikey quickly enough. And it won't sound like a power story initially. Mikey was one of the first patients that I had as a young resident that died. He was extremely premature. I don't remember gestational age at that time, but this is in 1976. The neonatal ICU had just been established 2 years before at Children's Hospital of Michigan. And so prematurity and how to aggressively manage it was really quite new. And Mikey had every complication known to mankind for premature infants, and he ended up having an intracranial hemorrhage that caused hydrocephalus, and it got infected, and it was just an awful course. And during my month on the unit, I talked to his mother, who was there faithfully all the time, about what was happening and tried to explain it in my own very immature kind of ways as well. And there was one CT scanner for the entire Detroit Medical Center. It was at Harper Hospital, the adult hospital. We had to put Mikey in an ambulance and ride around the block because the Children's Hospital and Harper are literally next door to each other. But we could not walk him across the mall to the other hospital. So we get the picture taken over there, and we're driving back, and she's asking me, and I've never even seen the CT scan, but there's a picture of his head, and there's a lot of black space and very little rim of gray space around it. And so I tried to interpret that for her, but advised her to make sure she talked to a real doctor. As it went on, Mikey was there for a long time, and he ultimately died. She and I sat together in the cafeteria and cried over his death. He was Mikey because he had been named after the little kid in the Life cereal commercial, which some of you may recall. Little redhead guy. He likes it. And her hopes and dreams were tied up in, in her hopes for the future were tied up in Mikey. And we parted ways, and I figured I'd never see her again. About 15 years later, I get a note from his mom, who has copied on a sheet of paper a little sticky note that I had left on the bedside crib when I had come by one day as a second year resident, and she wasn't there, so I just left a note. Hi, just stopped by to say hello, HG. She had a copy of this sticky note, and then she writes a letter saying that we're moving, and I've been going through, our possessions, and I found this note, and I just wanted to let you know that as a result of interacting with you after Mikey's death, I went to school and became an ultrasound technician because Mikey had so many ultrasounds done of his head that you explained to me so well, and I thank you for changing my life. It was at that, and I just found this letter again just a few weeks ago because we moved out of our home of 32 years to downtown Detroit to pretend like we're young hipsters. And which is working quite well, thank you. And it was probably the first time that it really made a really direct impression on me that people listen to us. People are impacted and influenced by us in all kinds of ways, some of which we understand, but many of which we don't anticipate or don't see coming at all. And then briefly, the story of when I felt powerless, also a baby story, and this is about Jumpin' Javon. Javon was another premature baby who had lots of difficulties, primarily chronic lung disease as a result of being vented for a long time, thus your neonatologist obsession. He had a stormy course and was admitted frequently to the hospital, and I was his doctor, and I saw him from the day he was born until the day that he died. And when he was sick, he was really, really sick. But when he was well, he was like a ball of energy. And he would stand in his crib, because he lived to be about 2 years old, and he would stand in his crib, and he would grab those railings, and he would jump up and down, thus the name, Jumpin' Javon, yes. And he was a delight, and his parents, it was the first baby, and his parents were a delight, first baby for them. And he suddenly and unexpectedly, as he was getting better, died. And I could not understand it. We had done everything right. We had invested our heart and soul into the care of this baby, along with his family. And how did this happen? I was asked to speak at a church 20 years later for Black History Month. And I speak, and the minister, I should have known better, asked me to speak at the morning service. When I finished, he said, "Can you do the next service too?" Well, no, man, I've been here for like 2 hours. You know, like, you didn't ask me that. And of course, I did it. And at the end of the second service, I'm standing in the line, you know, people coming in and speaking to me briefly. There were Javon's parents. And the mother says to me that, I don't know if you remember me. Oh, yeah. I remember you. I will never, ever forget you because you were, you know, and I didn't say this to here, but I'm thinking you were the biggest failure, you know, I ever experienced. And she goes on to describe how Javon was such a delight to her. She had 2 or 3 more children now, and they were doing fine, and that she would never, ever forgive herself because Javon was on a monitor, and she had not put him on his monitor the night that he died. And I'm thinking about, okay, so you feel sorry for yourself? Really? Are you kidding?
Power and powerlessness. They live pretty close to each other. And the subtleties of the story and how the stories hit us in any given moment kind of resurrect that strength of power, but also sometimes frame the acceptability that I may be powerless in this situation, but there's power all around me. Power in the moms, power in the babies, power in life, power in loss. I wish we could just stay up here and keep telling you stories and experiences, and I wish that we could listen to all of your stories because I know you have equally powerful stories. But we want to agitate you to think about helping us shift the narrative. It's a narrative that now does not other moms who happen to have some shared characteristics or some limited resources. It's a narrative that doesn't blame babies. It's a narrative that doesn't indict providers. It's a narrative that sees us coming together, both public health and clinical medicine, recognizing that our perspectives are all equally as important. The neonatologists and the peds intensivists. The frames are all needed to push ahead life for this population that we're battling so deeply. So I just want to invite Melinda and Cheryl to just give us one quick nugget. We've got like 3 minutes of what's the low-hanging fruit advice that you would throw out for people to think about as we go on through the day.
Well, that's not heavy, is it? I think low-hanging fruit, listening to our patients and families and being very deliberate with our listening and very deliberate with our recommendations and choices and getting the resources that you need. Sometimes we have a limited time with patients and families, so if you know that your patient population and your clients need things related to housing, food, transportation, have those things readily available so that when a person needs something, it's not as much as a challenge for you to help them. And, help them with the, again, not with the why, but how I can help you. So think about, as clinicians, as parents, as citizens, how you can help and the things that you can do as you move forward.
I think most of us have been delivering care and prenatal care the same way for decades. And not surprisingly, we're getting the same outcomes. We need to do something different. We need to disrupt ourselves. We need to think creatively. We need to bring innovation into this space. We're not going to be able to do it alone. We have to do it together. You talk about power. There is power in this room. It is so amazing. You should all come up here one at a time and look and see the diverse talent, expertise, and just incredible backgrounds of everyone. I'm looking around the room, and I know several people. This is something that we need to do to bring, so many people that are compassionate and giving the best care, but we need to figure out a way to do it differently. So I guess my biggest plug would be let's think about this differently, disrupt ourselves, and work together so we can do this.
So go forth and tell some disruptive stories for the sake of moms and babies. Thank you all very much.